We're live.
All right. Hey. It is Monday night, and we are back for part two. Hey, Dr. Dietrich. Hey, Dr. Khadijah.
Hey,
Yours truly, Dr. Carol Penn, and we are here with perspectives in primary care. And we are going to bring you part two of our special Father's Day edition. So last night we started on our journey discussing, how do we take care of our kings and our princes? What do they need to know? We started with vaccinations, we went to nutrition, and then I kind of framed what's going on and what are some of the critical differences when it comes to the care of African American men and men living in minority populations. Tonight, we're back with some more information. So, tonight, Dr. Dietrich is going to make sure you understand what screening tests do you need. This is hugely important in preventive care. And Dr. Kadish is going to make sure you get up and move and you know what, when, and how, the importance of exercise. And then I'm going to bring us home with some solutions for how we can begin to close the gap between what we see in healthcare that all men should have and why there is such a wide gap when it comes to African American men and minority men getting the health care that they need. Hope to be able to offer a couple of solutions that is evidence-based, that is coming out of the latest research. So, ladies, shall we introduce ourselves?
yes, I'm Dr. Dietrich Gorman, and I'm going to be talking about screening tests for y'all tonight. I'm also called America's Relaxation Doctor. I do speaking, and I'm also a best-selling author. So I can't wait to share a lot of valuable information for y'all tonight.
Excellent. Dr. Khadijah?
And hi there, I'm Dr. Kadisha, your board certified emergency medicine physician. I'm a speaker, consultant, and author of the best-selling book, Help Us Help You in the Emergency Room. It's what an ER doctor would tell you if she only had the time. And I'm also the creator of the Mobile MD Kit. I help people feel better, be safer, and better prepared for emergent medical situations.
Excellent. And I am Dr. Carol Pitt, board certified in family medicine and obesity medicine, and also your master movement meditation and mindset coach, best-selling author of my book, Meditation in a Time of Madness, a guidebook for talented teens, tweens, their parents, and guardians who need to thrive, and a speaker, consultant, and ready to come into your community to help you solve your healthcare needs and your mindset needs. Very important. Tonight's show is about education and information. We do not diagnose or treat anything on this show. We come to you bringing you evidence-based information, and we have a better relationship with your healthcare and wellness professionals. So you need to reach out to them after we give you this education and information. All right, ladies, shall we go?
Excellent, excellent. So I'm going to get started talking about screening tests. But I want to break things down and kind of back up from square one to get everyone on the same page. What does it mean to screen? What does screen mean? Screen means to discover or to detect something. Now, what is a screening test? A screening test is a test to see if you could potentially have a health issue or a disease, but you yet don't have the signs or symptoms of that condition. All right, so keep that in mind. But why are screening tests done? They're done as a preventative. Prevention is the key. We're trying to detect something early so that we can reduce the risk of further complications or develop an effective treatment plan before it gets worse, or if you start to possibly show some symptoms. And there's a couple of different types of screening tests. There's more of an invasive test, meaning you may have to give blood or something may need to enter your body. Then there's a non-invasive, and these are like where measurements are done or some imaging or just, again, it's not entering your body. So a lot of people, especially the guys out there, they may not admit it, but, they may be wondering, or thinking, should I be scared? you know. So no doubt just hearing the word test or that I'm going to have a test or a screen, it could possibly provoke some anxiety. But if you go into a screening test knowing that it's just a screening test and not necessarily a diagnostic test, I hope it'll help ease a little bit of anxiety that you're having. Now, I'm not going to be talking about diagnostic testing, but I do want to differentiate the two. So, like I said, a screening test is a test to see if you could possibly have something, but a diagnostic test is just that. Yes, you have this that we're testing for, just to simply put it. Okay, so just to run a couple of scenarios, you have a positive screening test, and then you're sent for a diagnostic test, and the diagnostic test is negative. Okay, so you're good to go. But if you have a positive screening test, and then you're sent for a diagnostic test, and that's positive, then this is at the point where you need to undergo further treatment or testing. Okay, so who is deciding if you need to get screened and why, right? You may be like, who, why? Well, it's going to be your physician or other healthcare professional. They'll decide if and when you need to be screened. And this is based on a few factors set up by different agencies who give us doctors' guidelines. They do their research, they look at the cost, they look at the benefits of screening, these guidelines to screen based on age, race, habits, sometimes your occupation, and then, yes, your gender. We're here for men's health, right? And these screening tests are geared to those who the disease or condition are more likely to affect and where most benefit to the person can be gained by doing this screening test. Now, this is just a brief summary of what screening in the medical sense is. And we've all heard that one of the keys for good health is prevention. And one of the ways we do this is by screening. Okay. So I'm going to be talking about screening recommendations for men. A lot of these screening tests, though, can be included for women, but there's definitely a couple that are specifically for men. And I'll briefly touch on most. And for y'all who are joining, I would really encourage y'all to write these things down. Please tag some folks. And, for the men who happen to be out here listening, I know a lot of y'all don't like to go to the doctor, and, but I'm going to implore you to go anyhow and get checked out. And for the women who are sitting there with their fellows listening, make them go. Just make them go. Okay. So we physicians and other healthcare professionals go by screening recommendations. And like I said before, there's different agencies that are based on research that provide these guidelines who the people should or should not be screened. And a big one that is used is called the U.S. Preventative Service Task Force, or the USPST. There's also other trusted sources like the CDC or the specific organizations for whatever you're screening for. And I'll mention them when and if I have to cite them. So I'm going to get started right off. The first one is prostate cancer. So the prostate is a gland that produces fluid that helps to transport sperm and to keep it alive. And this actually surrounds the tube that urine from the bladder flows through, called the urethra. All right, just to give you a quick anatomy lesson, right? But from the American Cancer Society, other than skin cancer, prostate cancer is the most common cancer in American men. The second leading cause of death in American men behind lung cancer. And estimates for 2020 show that about 191,000 new cases of prostate cancer and about 33,000 deaths from prostate cancer will occur. So that's a big number. So like 1 in 9 men will be diagnosed with prostate cancer in his lifetime. Prostate cancer actually develops more often in African American men and Caribbean men of African ancestry, and this is more than men of other races. Of course, it occurs in many other races. Men age 55 to 69, the decision to undergo a PSA, or prostate specific antigen test, a PSA, it actually should be individualized. And before beginning to get screened, you need to have this discussion with the healthcare professional. You want to weigh the benefits and the harms of screening. Screening actually offers a small potential benefit of reducing the chance of death from prostate cancer in some men. And actually, the potential harms of screening are like a false positive. You may have to undergo further testing, which may lead to a biopsy, overdiagnosis, overtreatment, which can lead to other complications like incontinence and erectile dysfunction. So, when you consider deciding to be screened, look at race, family history, ethnicity, other health issues that the man has, to determine what's best to do, and also if the man wants to do it. Okay, and it was recommended that we shouldn't screen a man if he doesn't have a preference for screening. Okay, and then also the USPSTF recommends against PSA testing for prostate cancer in men over the age of 70. All right. So then there's also the digital rectal exam. I know guys like to joke about, oh, I'm going to the doctor and he's going to have to glove up and all that stuff. But actually, the digital rectal exam as a screening test for prostate cancer is not recommended because of the lack of evidence for benefits. So don't forget, a screening test is before you have the symptoms. So it's not recommended to just go looking for that in the absence of symptoms in a digital rectal exam. Okay. I was surprised by that one too. The next one we have is colon cancer or colon cancer screening, colorectal. And this is actually a test to detect polyps in the colon. And it's done for adults age 50 to 75. But for African Americans, you can start as early as 45. And this is put out by the American College of Gastroenterology. African Americans have an earlier onset of the disease and higher incidence and higher mortality rates. And there's actually a few tests that are used for screening. And the one that most people out there are probably used to hearing is a colonoscopy. So in a colonoscopy, though, the doctor uses a long, thin, flexible, lighted tube, and this is inserted into the rectum, and is checking for any abnormalities in the entire colon. Okay, so it shows polyps, it shows ulcers, it shows, cancer, all that stuff. And then, hey, if it's normal, you got a reprieve for 10 years. And I get a lot of patients. I don't know if y'all do. I get a lot of patients say, "No, I don't want to do it. I don't want nothing in my butt." But I'm like, well, I mean, you ain't gonna feel it anyhow. The worst part is the clean out couple nights before, right? Do y'all get that?
Yeah, absolutely.
So it's like, just go ahead and do it. 10 years. I mean, really. So the next one is actually what's called a CT colonoscopy, a virtual colonoscopy, and you use CT scans to produce an image of the entire colon, and it's actually displayed on the computer. Then the doctor can interpret that. But that's done every 5 years. The longest bang for your buck is the actual visualization with the colonoscopy. Then there's a flex sigmoidoscopy, and this is just kind of the same principle, but it's not examining the entire colon, and you got to get this done every 5 years. Then finally, you have the stool test. There's ways to test the stool by testing blood in the stool, DNA in the stool, but keep in mind these tests are going to be done more frequently. All right. So the next one is lipids. It's recommended to screen men aged 35 years and older for lipid disorders, and men ages 20 to 35 if they are at an increased risk of coronary artery disease. And so some of y'all might be out there wondering, well, what lipids? So we're looking at the cholesterol, the good cholesterol, bad cholesterol, and there's certain variables that are desirable. Some are borderline, and some put you at high risk. And so that'll be determined by your doctor when you get the results. But if you're in that age bracket, hey, why not just knock it out? It's a blood test. Okay, so we know that having elevated lipids can possibly lead to cardiovascular disease as well as hypertension. And one of the things that is very important to screen for is what's called an abdominal aortic aneurysm, or a AAA. So this is actually recommended, a one-time screen via an ultrasound, in men that are aged 65 to 75 years old if they've ever smoked.
Mhm.
All right. And in men who have never smoked, it's recommended that the clinician selectively offers screening for the AAA with an ultrasound in this age bracket, rather than routinely screening all men of this age. But the clincher is smoking, if you've ever smoked. And this is because the net benefit in screening all men in this age group is small. If you do just every man with no history of smoking, so you might not get the biggest benefit in detecting this. And I just wanted to show you all out there a picture. So I don't know if you can see it. So if you can see this, the aorta is basically the largest blood vessel in your body, and it's located in the abdomen. And when you have this aneurysm, it's weakened and it's bulging. There we go. So you see the normal one here, and then the aneurysm here. So you see how it's really big, and so you can see if it keeps getting bigger and bigger, a lot of the times people don't know they have it because they haven't been screened, and it might be too late because when that thing pops, or blows, it's usually fatal. And so if you could just detect it by getting this screen, you'll be able to monitor it over the years, control your blood pressure, your cholesterol, and all that stuff. And just by getting a screen, like I said, you may not know that you had it.
Right.
Right. Okay. Then we're going to high blood pressure. It's recommended that screening for high blood pressure or hypertension in adults age 18 years or older. It's also recommended to keep in mind to obtain these measurements outside of the clinical setting for diagnostic confirmation before starting treatment. Because one of the things I know I always hear, oh, my blood pressure at home is normal, but it's just when I get to the doctor, because I don't like going to the doctor, it's going to be high. Okay, so a lot of the times, if we're just looking at that one elevated blood pressure in the office, it could be because of anxiety or whatnot. And so that's why we like to say, okay, well, give me some readings outside of the office. Let me see when you're at home, calm, and you're not doing anything. Write these numbers down because I take this diagnosis of hypertension very seriously. It's going to stick with you, so make sure we know what we're working with. Now, having said that, if somebody comes to the office and their blood pressure is like 250 or over 110, they have hypertension. You just never been screened for it or checked out. So we'll make that diagnosis right then. Okay. And so a lot of y'all might be wondering, oh, well, what are some normal numbers for my blood pressure? How do I know if my blood pressure is high? So a normal blood pressure is for the top number, which is the systolic blood pressure, over the diastolic, which is the bottom number. Optimal is 120 over 80.
Mm-hmm.
Then we have the stages: hypertension 1, 2, and 3. And I'll just go that the stage 2 is 140 or higher on the top number, or 90 or higher on the bottom number. Please look this up. I'm just giving you a brief synopsis. All right. Then we're going to go ahead and switch over to diabetes. All right. This USTFSP, it actually recommends screening for abnormal blood glucose in adults that are age 40 to 70 who are either overweight or obese. Offer patients with abnormal levels of intensive behavior, counseling, intervention to promote healthful diet and physical activity. And that's from the US TFSP. That acronym always gets me. Okay, now from the American Diabetes Association, their guidelines actually say testing for pre-diabetes and type 2 diabetes in asymptomatic people, which is a screen, should be considered in adults ages, any age who's overweight or obese, like if their BMI is over 25 or over 23 if they're Asian Americans, okay? And if they also have an additional risk factor, okay? And for all others, screening should begin at the age of 45. That's what's recommended by the American Diabetes Association. And if it's normal, you can actually repeat it in 3-year intervals, but more frequently, depending on the person's results, like if they were borderline, or if they've hurried up and gained a lot of weight, or if something has changed in their health, you might want to screen them a little bit more frequently or closely.
Right.
Okay. And so I said a term, pre-diabetes. Okay, you all may be wondering, well, what is pre-diabetes, right? So basically, pre-diabetes is where the glucose levels that are tested don't actually meet the criteria for diabetes per se, but it's still too high to be considered normal. It's like you working a point, you're working into it, all right, if you don't change your ways, all right? And some of the numbers, just to throw out there for you all to understand out there, um, in a fasting person, a person who hasn't eaten, impaired fasting glucose levels is like between 100 and 125. Or if you're actually going in for blood work and they give you what's called a sugar load or 75 grams of glucose, and then they test your blood sugar after that, it's considered abnormal if it's between 140 and 199. Or now they're starting to use the A1C. And the A1C is basically, it's like a measurement of, like, I always like to put it down, break it down like the amount of sugar that's on the blood cell, just to keep it simple. And that's typically a pre-diabetic is 5.7 to 6.4. Okay. Then a couple of more. I'm going to talk about hepatitis B and C. I talked about vaccines yesterday for A and B, so please watch the replay on that one. And it's recommended for hepatitis B for people who are at risk for acquiring the infection. And hepatitis C is actually, this is a new one that kind of came out in March. It's recommended screening for hepatitis C in adults aged 18 to 79 years old, period. Asymptomatic, period. Because before it was recommended for like baby boomers born between 1945 and 1965 and others at high risk. But now it says 18 to 79, asymptomatic, period. I'm like, oh, okay, I didn't know that. HIV. According to HIV.gov, there's approximately 1.1 million people living with HIV today, and about 1 in 7 don't know it. So it's about 14% of these people don't know it. And it recommends that clinicians screen for HIV in adolescents and adults age 15 to 65. And if older than 65, and if they have an increased risk of having the infection, they should also be screened. Okay. But according to the CDC, actually, African Americans, they actually account for a higher proportion of new HIV diagnoses and people with HIV compared to the other races and ethnicities. And in 2018, African Americans account for 13% of the US population, but 42% of the new HIV diagnosis in the US. And it's something else. And the highest group is African American male to male sexual contact. I'm going to keep it moving. I know we have our time. So concerning the eyes, and this one actually surprised me. The agency concluded that there's insufficient evidence to assess the balance and benefits and harms of screening for impaired visual acuity in older adults and glaucoma in adults. This really surprised me. So again, don't forget screening if the person is asymptomatic. Now, if you have symptoms, then okay, go get tested. Okay, so I got one more. Okay, lung cancer. According to CDC, cigarette smoking is a leading cause of preventable disease and death in the United States. And it's also accounting for more than 480,000 deaths every year. So 1 in 5 deaths. So that's a lot. And men are actually more likely to be current cigarette smokers than women. 16 out of every 100 men and 12 out of every 100 women are smokers. And it's recommended annual screening for lung cancer with a low dose CT scan in adults aged 55 to 80 who have a 30-pack year smoking history and currently smoke, or who have quit within the past 15 years. So, I gave a lot of different recommendations for y'all, and I really hope that you can pay attention to them. But I do have some main takeaways from everything I just said. The first takeaway is have your regular checkups and screening tests. I mean, just go, just get it done. Okay. Ask your healthcare professional, are there any screening tests that you need to have? Be proactive in your healthcare. Ask the questions. The third thing is to actually keep in mind that a screening test is not necessarily a diagnostic test. Okay, we're checking to see if possibly. And also, just because there isn't a recommended screening test, it doesn't mean that you can't have an exam or be tested, like, glaucoma, or even, like I said, I didn't mention skin cancer. That's one of them. There's not really a guideline in asymptomatic people. So, look at your skin. I mean, if you have a reason, go get tested, and discuss this with your doctor. Okay. Again, a screening test is to test people who don't necessarily have the signs or symptoms. And then the fourth thing is knowing something early can possibly lead to restorative treatment, right? Slowing or halting down the disease progression or optimizing treatment, but you have to get it done. And the fifth thing is don't be scared. I understand definitely the unknown can be scary, but just do it. And then the final thing is prevention is the key. Just get it done. And so one of the ways of preventing things from occurring as far as your health is to adapt a regular exercise program and an exercise regime. And I know Dr. Khadijah is getting ready to tell us all we need to know about exercise. Get those joints moving.
Absolutely.
Certainly.
Dr. Dietrich, that's a great way to segue into it. And first, before I go into the exercise portion, I want to thank everybody who are watching tonight and who've made their presence known in the comments. We've got Dr. Ken, who mentioned that he doesn't think men make time for their health, either neither physical nor mental, because they may not trust the health system. And Dr. Carol tied things up last night wonderfully in her discussion of that. I believe she will touch on that again at the end tonight. Also, let's see, we've got Coach Leah Denley in here. We have Marlene Reeves. We have Harry Carter, who's a coworker of mine, and he's very healthy. He's like, I hope that he makes some comments about exercise, because he even exercises at work. He finds minutes here and there during the workday to use his resistance band to work. He's a great example. And there's more.
We have a freeze.
Okay. And I also have to say that, let's see here, that with regards to preventive,
I think we have a little technical difficulty there. So there goes.
It happens.
Wi-Fi, my goodness. Dr. Khadijah will be right back. All right. So my goodness. So sorry for the technical difficulties. She will join us back when she can. But so let me just go ahead and acknowledge some of the people that are in the chat. So Dr. Tanya, Coach.
Hi, Dr. Tanya.
Tanya, thank you so much for tuning in. We also have Coach Leah. So there's Dr. Khadijah. She's back, a little connectivity difficulty. So I was just recognizing Dr. Tanya and Coach Leah for their participation tonight. So I don't know if you want to take it from there and wrap up and go into your segment on exercise.
Okay, great. So thanks, guys. And yes, like storms are roaming through the Houston area. One thing I have to say about what Dr. Dietrich mentioned is that an ounce of prevention is worth a pound of cure. And if you don't pay attention to prevention, you're going to end up seeing me with a hypertensive emergency or hyperglycemia, meaning it's elevated blood sugar, things like that. And you don't want to end up in the ER simply because you did not pay attention to your preventive care needs. Okay, so
exactly.
Another part of prevention is physical activity. This is something that you can do tonight to get started on improving your health or the health of that man in your life. So like Dr. Carol mentioned yesterday, the key to healthy weight is nutrition and exercise, and it's about 80% nutrition, 20% exercise. Some people may say slightly different. percentages. And I discussed nutrition yesterday. And just to help you relax, everything that I'm discussing is on my website at drkhadishamd.com. So with that, I'll get started. So the benefits of physical activity. Physical activity is the key to increasing muscle mass, strength, flexibility, mood, even sexual function. I mentioned that yesterday. If you lose about 5 or 10% of excess body weight, your sexual function can improve men. So it decreases stress, depression, diabetes, heart disease, the risk of certain cancers, and it even lowers mortality rate, early mortality rate. And the first thing, and then another thing I have to mention is before getting eager and saying that you're going to engage in a high level of activity, do speak with your physician first. You can also just start slowly. And if you have a chronic disease, especially consult with your physician before increasing your physical activity. Mm-hmm. And my information mainly comes from the CDC, Harvard, and Men's Health. So the CDC says that there are 2 types of physical activity that we all should engage in each week for a total of about 150 minutes. There's the aerobic activity, which is walking, jogging, cycling, the treadmill, and then there's muscle strengthening, AKA resistance training, and that should be about 2 days a week, involving your legs, your hips, back, your chest, your abdomen, in addition to shoulders and arms, because I have to say, a lot of men like to focus on their shoulders and arms and not their bellies, or they want to focus on muscle building instead of cardio, because they're afraid they're going to lose muscle or lose size if they get to, if they shrink down too much. And actually, the CDC is saying that cardio is a bit more important than the muscle strengthening. They're both important, but the cardio is a bit more important for heart health. So the types of muscle strengthening that we know about, lifting weights, the resistance bands. You don't have to buy anything. You can do push-ups, sit-ups, even heavy gardening. Even that counts as muscle strengthening, even a bit of cardio as well. And then there's yoga also. So more on aerobic exercise. It's recommended that one does 40 minutes of moderate to vigorous aerobic exercise about 4 times a week. If you do it for about 6 months, it can improve erectile dysfunction, according to a 2018 study in the Sexual Medicine Journal. Okay, the type of exercise doesn't matter, but the intensity. But even brisk walking, jogging, cycling, circuit type training, those things are good. You can go to the gym, or you can follow online workouts. YouTube is typically free. There are tons of workouts on YouTube. There are tons of trainers on YouTube who you can follow. You can even speak with them through Instagram, things like that. So you don't have to buy a gym membership. So don't let that be an excuse. And also regarding like pelvic health, Kegel exercises, they're not just for women. These are exercises to help strengthen the pelvic floor muscles, and it increases blood flow to the penis. And the motion is similar to what you would do to stop the flow of urine or to hold back flatulence or gas. And you can do Kegels routines, and they can vary from 10 reps to 100 reps. And for more information on that, you can check out my PDF, and I refer to Harvard on that. So if you're not used to vigorous activity, again, do check out, go see your primary physician first. And so I just wanted to also maybe discuss a couple of excuses that people use, or and then like the issue of like not intermittent, fasting cardio. So some people say, fasting cardio is good. It increases the caloric deficit which will help you lose weight. And fasting cardio is basically like doing some cardio activity, walking, treadmill, any variety before you eat in the morning to increase that deficit. But then there's also research that says that doing so much cardio before you work out can tire you out before resistance training. So I know from my experience, some trainers will do just a little bit of cardio to warm you up. Then they do the resistance training and then do cardio afterwards. But I know there's like a raging debate over whether or not you should do fasting cardio and whether or not you should do cardio before or after training. So some excuses that people may have. So one is, with my work schedule, I may not have time to exercise. Now, again, don't look at exercise as this enormous task that you must take on. You can break it up into little pieces. You don't have to do a whole hour a day. You can break it up into 30 minutes in the morning, 30 minutes at night, or even 15-minute intervals throughout the day while at work. Just like my coworker, Harry Carter does, if we have no patients at the time, he's using his resistance bands. The rad techs are doing lunges around the nurse's station. There are different things that you can do even at your desk to to get that cardio in while you are working. Also, if you are the only one in the house who is trying to embark on increasing your physical activity, you can definitely find support online, friends who go to the gym. You can have your, there's a whole nother support system outside of the house. They don't even have to be in your face. They can be online. So you can get support and accountability that way through online groups, or, if you're venturing out to the gym, folks who go to the gym with you. And again, you don't have to be huffing and puffing and, sweating profusely to get in effective exercise that increases your overall health. It doesn't have to be super intense. Again, it could be, walking. A half-hour walk after a meal daily has been shown to decrease the risk of stroke, help reduce one's progression to diabetes, all of those types of things. So in the interest of time, again, you can see what I'm talking about and more on the PDF that I provide. And I want to give it to Dr. Carol.
All right. Well, thank you so much. Thank you both, Dr. Dietrich and Dr. Khadijah. Such powerful information. I think there's so much information here. We could have done a part 3 on this. And, we shouldn't just leave a show on men's health to be, just on Father's Day. So we're going to have to change that up a little bit, because there really is a deficit. Men do not go to the doctor of whatever race or ethnicity as frequently as women do. And we've been emphasizing prevention tonight. So it's always, prevention is, an ounce of prevention is worth a pound of cure. And that saying could not be more true. And so we want to emphasize prevent, prevent, prevent. Work with and find a primary care medical specialist that you are friendly with, you feel good with, you feel familiar, and you can share with that person, so you don't ever have to go see Dr. Khadijah. Now, Dr. Khadijah loves her patients and she'd love to see you, but if you're in front of her, it's an emergency. Mm-hmm. And that's what we want to avoid. So we're talking about prevention. So last night I talked about the mistrust factor. that exist in African American men as well as other men from other ethnicities, such as the Latino and Latinx community, tribal communities, as well as some of the other smaller minority ethnicities and communities. And we cited one big research study that ended in 1972. It's like 1938 to 1972, where the U.S. Public Health Department conducted an experiment with syphilis, telling these men that they were treating them, which was a flat out lie. They weren't treating them. They were just, seeing, well, what were the long-term effects of syphilis? So these men then turned around and infected their wives. And there was decades of suffering and harm in the African American community. So this is, recent memory. So this was cited as a huge study that occurred in the modern era that contributed largely. And of course, there are other things, and you look back in history, there's more, but this was our point of departure last night. So what's some of the solutions? So again, I wanted to look to see what's the latest research. So this research was actually conducted back in 2018, but it was cited recently this month, as a matter of fact, in the New York Times. And it's, the article is called "The Secret to Keeping Black Men Healthy." So I'll share a little bit with you what the study was. And currently, to this day, Black men on average live 4.5 years shorter or less than compared to their white counterparts. And this is controlling across for everything, education, economics. So it doesn't matter if the African American man is educated or if he's well off, it's still the same outcome. So Black men actually have the lowest life expectancy of any ethnic group in the United States. And then much of this gap is explained by greater rates of chronic illnesses such as diabetes and heart disease. And what did you hear Dr. Dietrich talking about tonight? The screening that is necessary to prevent both diabetes and heart disease, and the age at which you need to start to get screened. And also, this also affects people who are in lower socioeconomic status as well as less education. So that does have an impact as well. But we have to ask ourselves why. Is it all because of lack of insurance? Is it all because of lack of access to healthcare? So these researchers in California concluded after their research, and this answer might surprise some, it has to do with a lack of Black physicians. So it's the lack of Black doctors. And the research was pretty startling. So bear with me. So although 13% of the US population is Black or African American, just 4% of the doctors are Black. The study was published in June by the National Bureau for Economic Research, and it involved 702 Black men in Oakland, California, who came to a clinic for free health screening. They were randomly assigned to a Black male doctor or one who was white or Asian. Now, if anyone knows a little bit about Oakland, California, you know this is a very diverse city. But it was striking that when they were trying to put together the doctors who were also, randomly assigned, they could find the 14 white doctors, but they couldn't find the 14 other doctors. So they had to artificially construct that, and they actually used medical students and went to medical schools because, again, that number is very real. Just 4% of doctors are Black. So neither the men nor the doctors knew that the purpose of the study was to ask if a doctor's race mattered when he or she advised these patients. As it turned out, the racial effects were not subtle. Diabetes screening was a part of the health check, and 63% of the Black men assigned to a Black doctor agreed to the screening, but just 43% of those assigned to a doctor who was white or Asian consented to be screened. Some 62% of Black men with a Black doctor agreed to cholesterol tests, compared to 36% assigned to a doctor who was not Black. Now, you just heard Dr. Dietrich, she just ran it down. These are the life-saving tests. These are the tests that directly correlate and tie into longevity. And so what was different here was that previous studies have been observational. They were mostly searching earlier data for trends. And this is a much weaker form of evidence, and the results were mixed. This study showed that when done live and, like in living populations in real time, striking difference. You can't argue with it. So the researchers ended up employing minority pre-medical students to recruit participants by visiting 20 barbershops and 2 flea markets in Oakland, offering Black men vouchers for a free health screening. The screening was at a clinic set up by the investigators and staffed by 14 Black and non-Black doctors. The men were offered preventive measures like flu shots and screenings for blood pressure, cholesterol, and diabetes. The men who came to the clinic offered equal praise for their Black, white, and Asian doctors, but the patients were far more likely to consent to preventive care, screenings, and vaccinations when their doctor was also Black. If Black patients were to agree to this preventive care at these rates in the real world, and here's where it gets very significant, the gap in cardiovascular mortality between Black men and the rest of the population could be reduced by 20%. That's huge. That's real numbers, and that's real lives. What's the number one killer? Cardiovascular disease, right? So we need, and you say, well, it would be great, to recommend that African-American men seek out an African-American doctor, but this is a real problem because that's 4% total. So that also includes African-American females. And again, the treatment and the care and men willing to seek preventive. So, Dr. Dietrich, Dr. Khadisha, the colonoscopies, for example, and that again, men do feel some kind of way about, their private parts and whatnot. It's one thing, and they do kind of shy away from a female wanting to talk about it. And if there were more African-American male doctors talking to African-American men about the importance of this life-saving screening care, again, we would have much better outcomes and we'd be saving lives. So the study goes on to ask, why would Black doctors have such an effect? Perhaps they use more nonverbal cues to communicate empathy, suggested Dr. Amber Bernardo, a professor of medicine and healthcare at Dartmouth College. Well, it was very interesting that it seemed that the Black men who saw white doctors would write comments afterwards like, it was a great and fast experience. Doctor was great as well, and very informative, very appreciative. Yet when they saw a Black doctor, this is what the feedback and the comments were. The entire day made me feel very comfortable and relaxed. The doctor was a really cool doctor. So you see the difference here. One is kind of like, oh, I appreciated it. And the other one was, that heartfelt response. There was an emotional connection. There was an I feel it going from the head to the heart. And so they just noticed that the difference in connectivity and the difference in languaging, and this provoked a different response in the Black patients. So, this is something that we're really going to have to work on, and we're really going to have to consider. It is very important. And one thing that I would like all of the people who are participating in the audience tonight, You want to look up organizations like the Black Men's Health Initiative. You also want to look up the oldest professional medical organization in the country, the NMA, National Medical Association. There's the AMA, which is the American Medical Association, and then there's the NMA, which was founded by Black doctors, actually a few years ahead of the AMA, because the Black doctors already knew that they were not going to be welcomed in the AMA. So they jumped out ahead of the curve and they formed the National Medical Association, which is, celebrating over 200 years as an organization this August. And it's too bad because the conference has to be virtual because of COVID-19. But if you go to the National Medical Association website, there's lots of information out there. It's also important that more Black men and women get involved in research studies. Most of the research is done on adult white males. And there are differences. There are differences in how disease manifests and when it manifests. So we need to have research that is conducted by us, for us, so that we do find out these differences. So this is really powerful when you come up with a number that if this was happening in real time, there'd be 20% more men, African American men, who have cardiovascular disease prevented. So, this has been, so much. And I don't know if you've got any additional comments there. And we definitely are, asking people to go to these websites, to check out the research, to, come on over to my website there also. And, each of our websites, I'm at www.drcarolpenn.com, drcarolpenn.com. There's information there, how you can engage with us individually and collectively. Let us come to your organizations. Let us speak to your minority populations. Let us work with your HR departments on how we can get it done, how we can move it forward, how we can shift the needle, and how we can all have greater health, wellness, and optimized health and wellness, especially our kings and our princes. All right, I think it's just about time for us to get ready to get out of here, ladies. What do you say?
Yes, and yeah, we've kind of running out of time here, and I just wanted to say thanks so much for everyone who's been in the comments. Before I hand it off, let's see. So Stanley was in the comments. He said that the information is good. Dr. Kalani is in the comments as well, and she also put the acronym and for the National Medical Association. And let's see, there were so many comments here. I just wanted to thank everybody who came.
I love Coach Leah. When you think of the systemic racism that has existed for the last 100 years, it's a wonder that life expectancy number of years between Black men and white men isn't much larger. Yeah.
Yeah.
It's true. But even that 4.5 years, that's too much, and that shouldn't be. That should not be.
And again, please listen to what Dr. Dietrich was saying, what Dr. Carol was saying. Don't let our our cultural differences or the history of distrust keep you from getting the care that you need, because regardless of what you believe, you are still human, and these processes are still we're still vulnerable to these processes no matter what you think. And and if you don't pay attention to prevention, then you may end up in the ER with a much more serious situation.
And you deserve quality of life. And take responsibility as well. Ask the questions. Like Dr. Carol was saying, find someone you feel comfortable with, so you can feel open enough to share what you need to share to get the best health care.
And also, you as consumers have much more power than you realize. If you're engaging with these medical organizations, you say, look, I know that everybody here is a competent professional, but I do want to have a Black or Hispanic or, so name it, just name it, just name it. And guess what? They respond because they want your dollars. So you vote by giving them your business. And if you're not seeing yourself reflected in the structure, bring it up. Bring it up. They want you to remain as a patient. They again, they want your business and they need your business. So you have a lot of power. Say, well, there must be someone in this city. There must be an African American doctor in this city that you can refer me to. Refer me to the African American cardiologist. Refer me to the African American urologist. Refer me to the African American primary care doc. And, they might kind of look to the left or the right and assure you that, well, all of our doctors, and you can then say, well, there was a study in the New York Times that says that's not true. It makes a difference currently in these United States in healthcare delivery. If I as a Black person has a Black doctor, and, they can't argue with the legitimate research that's coming out of institutions, University of Connecticut, the CDC, Dartmouth, all of what has been cited over the past 2 nights. So the power is in your hands. Ask for what you want and what you need. And ask them, doctor, this is another thing. You're prescribing such and such a medicine for me. How many people of minority background or African American were in that research study? Because guess what? All of that information is detailed and all that, all that stuff and all that paperwork that comes whenever you unpack or you look at a medication. And know your medications, know the names and the dosing amounts. And you can ask them, wow, when the research was done, were people with my background included in that? How do you know this is the best medicine for me? There are 5 medicines that are related. So how are you making your decision? You can push us a little bit. You can challenge us as doctors. All right. So please do that. Coach Lee.
Thank you.
Yeah.
Okay. Thank you so much.
All right, everybody. Thank you. We better go ahead and get out of here. So stay tuned for the next Perspectives in Primary Care. And this is yours truly, Dr. Carol Penn, Dr. Dietrich, and Dr. Khadisha. We are signing off for now. It's been great. Thank you for your time and attention last night and tonight.
Thank you. Thank you very much. Bye-bye.
Bye.